Next, we have Dr. Malarvizhi from Chennai, presenting Listening to the Silent Struggle, History and Clinical Examination of OSA.
Good morning to one and all. I am Dr. Malarvizhi. I am basically an assistant professor, so my talk will be more focused on UG and PG, TG rather than a talk with a consultant. So in case I miss anything, I would expect my chairpersons to add on. So the primary point of coming for this session is how to identify the symptoms of OSA and how to perform a focus history and a structured examination so that you will know where the obstruction level is, and to recognize high risk patients and to decide the appropriate investigation so that we can move on to the staged surgery that we can help the patient. So the burden of OSA, it's around prevalence of 2% in women and 4% in men. It's often underdiagnosed and it has a major health and economic impact. So pathophysiology, so it is basically an upper airway collapse. There are certain factors like central factors based on neurovascular disorders and obstructive as in anatomical. You have the nose, you have the oropharynx, you have the larynx, and occasionally you have mixed. So the pathophysiology was based on sleep. Your muscle will relax, following which your pharyngeal dilator muscle tone will have a more relaxation. Your airway narrows at certain areas such as your velum and your base of tongue, which leads to apnea. So when you have apnea, there is increased carbon dioxide retention and reduced oxygenation, which will cause a brief awakening, and the airway reopens by snoring or gasp, and the patient awakens and returns back to sleep. So this kind of fragmented sleep leads to a dynamics, daytime somnolence, and which is due to the hypoxia, which can cause an increased sympathetic tone and thereby increasing your risk of metabolic disorders such as hypertension. So the risk factors that we commonly contribute is obesity, the male sex, the increasing age, craniofacial anomalies, use of alcohol and sedatives, hypothyroidism, and pregnancy. So the clinical history we'll focus on is snoring, witnessed apneas by the bed partner, gasping or choking, which the patient himself will say, restless sleep, nocturia, dry mouth in the morning, morning headaches. So daytime, the patient will experience excessive daytime sleepiness, fatigue, poor concentration, memory impairment, mood changes, and reduced work performance. In children, pediatric age group, very commonly there will be a very poor concentration in spite of the child sitting and learning in the evening. Morning, the child may be not able to have a good scholastic performance. So target history will be history of hypertension, diabetes, coronary artery disease, stroke, heart failure, arrhythmias, and GERD. Sleep history, we need to know about the sleep schedule, what time the patient sleeps, what time he wakes up, in between how many times does he wake up, what is the awakening, does he get up with a choking or gasping spell, what does the bed partner say about his sleep, whether there is a crescendo or sudden apnea, shift work of the patient, if he is having a routine shift or a change in shift every week or month, and sleep hygiene, how well the patient is going to sleep, whether he uses a lot of screen time or he has some exercise activity before bed, or the time lapse between the dinner and your maximum hour sleep. So use of drugs, alcohol, smoking, opioids also has a major role, and family history of shared habits, the everyday activities, the lifestyle, the food, and which contributes to the metabolic disorder has a major impact. So screening tools are stop bank questionnaire that we commonly use during our history taking, Epworth Sleepiness Scale, and Berlin questionnaire. So Epworth Sleepiness Scale, so you have the, I hope it is clear. So scoring starts from 0 to 3. So 0 is no snoring, never, to 3 is high chances of dozing off. So in this scale, we will be talking about during history examination, history, sitting and reading, how much is the chance of the patient going for sleep, watching TV, sitting inactive in a public place, it can even be a bus stand or a railway station, passenger in a car for an hour, lying down to rest in the afternoon, sitting and talking to someone, sitting quietly after lunch with no influence of alcohol, stopped in a traffic for a few minutes while driving. So this scoring will give you the risk. So 0 to 10 is quite normal, 11 to 15 is mild to moderate risk, and 16 to 24 is severe risk. So the next questionnaire we use is stop bank. It's a validated OSA screening tool. So S means 0.1 and no means 0 points. So you have snoring. Does the patient snore loudly, heard enough to be behind the closed doors? Is the patient tired, sleepy or fatigued during daytime? Is there any observed choking or gasping during sleep by the bed partner? Does the patient have high blood pressure? Documented. Is the patient's BMI more than 35? Is the age about 50? Is the neck circumference above 40? This is actually an arbitrary one, but we use it very commonly in other questionnaires also. The neck circumference due to increased muscle tone and deposition of fat. The gender, male, because men being having more muscular mass, it has a greater risk. So the interpretation is score of 0 to 2 is low risk and 3 to 4 is intermediate risk and high risk is score 5 to 8. So based on that, we'll go for further investigations. So in general, BMI, neck circumference, waist circumference and blood pressure. A BMI above 40, a neck circumference in male of more than 42 centimeter and in females about 39 centimeter, a waist circumference of more than 102 in male and more than 88 centimeters in female are considered risk, and a documented high blood pressure is also a risk. Besides that, you have the craniofacial anomalies. So as my previous speaker said, your craniofacial anomalies are the major ones that contribute to poor prognosis. So retronactias, micronactias, midfacial hypoplasia, facial asymmetry. So in the nasal part and the oral part, which contribute commonly to obstructive sleep apnea, are nasal septal deviation, gross deviation with compensatory hypertrophy of turbinate, a nasal valve collapse may be congenital or post-traumatic, polyps in the nose also contribute to recurrent oral breathing leading to apnea. So the oral cavity, the tongue size, the tonsil size, provided it has a more posterior, occupation of the oropharynx, your soft palate, uvula, hard palate, all these contribute in the form of anatomical contributing factors. The tonsillar grading, very commonly used, the Brodsky scale. So grade 1, so tonsil still within the tonsillar fossa, less than 25% obstruction. So grade 2, 25 to 50, extending a little outside the pillars but still not a major thing. So grade 3 to and grade 4 are major contributing factors to OSA in the form they are outside the pillars with occupation of oropharynx in the posterior and the medial aspect. So Malarvizhi classification is basically you keep the tongue protruded out and see for whether you are able to visualize the tonsil, uvula and soft palate very well. So if all these three are very well seen, it's low risk OSA in Malarvizhi. In class 2 it will be soft palate and upper uvula only will be visible. So there is a mild risk. Class 3 is soft palate and base of uvula only will be seen. Here there is a moderate risk, and if only your hard palate is seen, there is a high OSA risk. So the next staging, Friedman tongue position and the Malarvizhi has only one change. Basically Malarvizhi has the tongue protruded out, whereas your Friedman tongue position keeps your tongue back inside in resting position in the oral cavity. So in Friedman stage 1 you will be able to visualize the uvula and the tonsils, and 2A is most of the uvula but not the tonsils. 2B is visualizes the entire soft palate up to the uvula base, not tonsils, and in stage 3 you will be able to visualize some part of the soft palate, and stage 4 you will be able to visualize only the hard palate. So the Friedman staging system uses the Friedman tongue position, the tonsil size and the BMI. So it has 4 stages, and as you can see based on his Friedman's paper, the stage 1 people had around improvement of 80% post surgery, and stage 2 around 37.9, stage 3 around 8.1%. The stage 4 is BMI above 40 with any of these positions, Friedman tongue position, tonsil size, and the journal doesn't exactly give the prediction percentage but says as poor prognosis. So dynamic examination of the patient, which you will be able to get a clearer idea about the muscle tone. So Muller's maneuver, awake endoscopy and drug-induced sleep endoscopy. So in flexible nasopharyngoscopy, which is basically DICE, so what do you look for? So you give the patient a sedation, either propofol or dexmedetomidine, and you use your flexible scope to visualize the collapse at the level of your velum, oropharyngeal lateral walls, tongue base obstruction, epiglottic collapse. So basically the OAT classification, and then based on it you will be able to see where the level of disease is. So the red flags here are central apnea, obesity, hypoventilation, heart failure and neuromuscular disorders. So the slides do not project a Berlin questionnaire because we hardly use it. In that you have 3 categories. Category 1 is snoring, apnea, and category 2 is daytime fatigue, category 3 is obesity and hypertension. So the investigations that we routinely do is home sleep apnea testing, this is besides the DICE, and polysomnography, which is gold standard, and based on that the AHI will be interpreted. So polysomnography will be dealt a much elaborate way in the next presentation. So the monitors generally used here is EEG, EOG, EMG, ECG and SpO2, airflow, respiratory bands, body positioning and video recording. So there are different levels of study, and along with it we will be doing skeletal landmark cephalometry, CT and MRI, preferably dynamic MRI, DICE, and we rule out metabolic disorders such as thyroid, polycythemia, diabetes and heart failure disease. So the clinical pulse here is history predicts the severity. Combining the symptoms with examination and not including the BMI alone for your criteria, you need to examine the entire upper airway both in static and dynamic form. So that will give you a structured history taking and examination, and along with the screening tools you can predict the level and the severity and the prognosis also. I hope I am clear about this. Any questions or like take on will be welcome.
Excellent presentation, ma'am. As you told, no, it's a very good presentation for postgraduates. So if they get in theory exams, they can just reproduce your slides so that they can get good scoring actually. Excellent.
Madam, thank you for a very thought-provoking and excellent presentation. The main focus is like you have emphasized clearly that
History.
clear, meticulous clinical examination and systematic history. That is more important. That proves that this is the most important part of any medicine. So that's fine.
Thank you.
Thank you.
Thank you for giving the opportunity. Hope everyone will utilize this session. Thank you.
Thank you, Dr. Malarvizhi.